Yang berbahagia Tan Sri Dr. Noor Hisham Abdullah, Director General of Health. Thank you so much, Tan Sri, for taking time off your very busy schedule to be present with us here this morning for this special address and dialogue session. We wish at the outset to thank you once again and all of your team in the Ministry of Health and all of your frontliners and volunteers for the very hard work that have been put in over almost the last 2 years now in the fight against COVID. The whole country appreciates the fine efforts that you have led the Ministry of Health with the support of your entire team in combating this invisible enemy. So thank you so much, and we salute you, Tan Sri, and your team for your hard work. We have seen lately a huge increase in the scale up of the vaccination efforts with the National Immunization Program now vaccinating close to 500,000 people daily. We have seen also an expansion of medical facilities and upgrading of some of the hospital requirements. And hence, I think we hope that we would be able to soon turn the corner in this fight against COVID. But before we move on, Tan Sri, perhaps I should just very briefly highlight to you what the conference discussed yesterday. Yesterday's sessions highlighted the need for public-private sector cooperation in healthcare, as well as a need for health reforms and a proposal for the setting up of a National Health Commission. The discussions yesterday also spoke about digital health and mental health. So this morning we started off with a session on private equity in healthcare because increasingly we see a greater role of the private sector, and we hope that you will be able, Tan Sri, to share with us your thoughts on the state of the healthcare system in Malaysia, perhaps sharing the priorities of the Ministry of Health as well as public-private healthcare collaboration, but perhaps more importantly, to give us an update on the fight against COVID-19, which is the biggest challenge facing the country. So without any further ado, may I hand the floor over to Yang Berbahagia Tan Sri Dr. Noor Hisham Abdullah. Tan Sri.
Thank you, Tan Sri Michael Yeo, President of KSI Strategic Institute of Asia Pacific. Excellencies, distinguished speakers and guests, members of the media, ladies and gentlemen, Bismillahirrahmanirrahim, Assalamualaikum warahmatullahi ta'ala barakatuh, salam sejahtera, and a very good morning. I'm delighted to be here this morning to deliver the special address at the Malaysian Healthcare Conference 2021, which brings together eminent industry leaders, policymakers, and delegates from across multiple sectors. Let me take this opportunity to thank the organizer, KSI, for inviting me to share some of my thoughts on the industry and its future. Improving healthcare system is certainly a constant challenge. And today, the global pandemic highlights this as a challenge of the utmost importance that the public and the private sector must take on together. We must work together. And the slow progress of modernization and strengthening of the healthcare system hampers the fight against the pandemic, which continues to spread at a high speed. It is now a matter of strengthening our resolve for greater efficiencies to make public health better. Solutions exist to strengthen our health system, reinforce focus on prevention and more effective management of chronic diseases, make greater use of digital technologies and data, and encourage multi-sector collaboration to seek innovative approaches and secure the needed investment and resources. The new age in healthcare is inevitable when all the stakeholders actively work together towards a common goal, and we can find the solutions to even the most difficult challenges. Now, ladies and gentlemen, COVID-19 pandemic is a wake-up call for all of us in the public health, and a revamp of our healthcare system can no longer take the form of a long, winding road bordered by good intentions. Rather, it is now an urgent requisite, and change must happen faster to avoid the full brunt of the future catastrophic events like the pandemic. It is without doubt that overhauling a healthcare system is an onerous undertaking and requires many stakeholders' engagement in concert behind common and complementary goals. However, the COVID-19 crisis has shown that it is possible to make wide and large-scale changes when certain hurdles are overcome through innovation and concerted coordination from all stakeholders. In the same way, similar shift in the post-pandemic world must come in a form of incentivizing and rewarding effective prevention. In other words, we can and must do more to prevent and better manage our health issues in life before costly and sometimes irreversible damage occurs. This is good for individuals, system, and the entire societies. Now, before I come to the ways we can implement a more effective prevention and management of our healthcare system, allow me to recap what is Malaysia's health system. Malaysia's existing healthcare system, comprising of the public and the private system, a two-tier system, a dichotomous healthcare system that we have embraced over the years. The private system mainly caters for the urban population and those who can pay, while the public system provides access to everyone, including civil servants, with token payments being imposed. The existing two-tier system has so far served Malaysians well, but it is no longer sustainable. We all know this. It is time for us to relook back how we can transform our healthcare system, public and the private sector. The healthcare system, like most around the world, has been organized around acute, often catastrophic illnesses. However, there needs to be a stronger emphasis on preventive and promotive healthcare, which is more cost-effective and leads to better health outcomes. Furthermore, advances in predictive medicine should be harnessed to enable prevention and early treatment of diseases. The way resources are mobilized to support the healthcare system and how it is organized for service delivery and its influence on health status is also important for its influence on the other aspect of the country's social, economic, and political well-being. The healthcare system needs to focus on improving health status and promoting social well-being by ensuring equity and access to the healthcare. Health resources should be used efficiently. Clinical effectiveness has to be enhanced. There should be improvement of quality healthcare services with an enhanced patient satisfaction. Last but not least, the healthcare system must be sustainable. Ladies and gentlemen, we can implement a more effective prevention and management of the healthcare system. Firstly, we need to double down on prevention and more effective management of diseases. Secondly, accelerating the adoption of digital technologies and data integration. And thirdly, building a multi-sector approach to encourage investment and resourcing behind innovation. Doubling down on prevention and more effective management of diseases, despite the recognized benefit of preventive health measures, more can be done to ensure that our healthcare system is set up to encourage healthier lifestyle and reward better health outcomes. Take chronic diseases, for example. Even before COVID-19 brought our hospital to the brink, the burden of chronic conditions weighed heavily. 1 in 5 adults, or about 3.9 million people aged 18 years and above in Malaysia, suffer from diabetes, according to the 2019 National Health and Mobility Survey. The diabetes prevalence in Malaysia has increased to 18.3% compared to only 13.4% recorded in 2015. About 49% of the diabetic in Malaysia have never been screened or diagnosed with the disease. The above are largely inevitable burdens of the disease if we take a population health approach targeting effective prevention among those most at risk. When well controlled, these diseases will not take such a heavy toll. Patients who reach and maintain goals established through medical guidelines live healthier lives and encounter far fewer burdensome and costly complications. However, real-world experience has also shown that these goals are often not met, and patient and healthcare practitioners continue to struggle to effectively manage the disease. There's a need to tailor health interventions to these segments of population before they progress to the irreversible disease. We need to encourage a holistic lifestyle applications and engagement that can fill in the gaps in the months between clinical check-ins. This is where digital technology comes in. Second is accelerating the adoption of digital technologies and data integration. Digital adoption has been accelerated during this pandemic with various initiatives through interagencies, ministries, collaboration, and industry support. I just heard the earlier interesting session on discussion on digital transformation. And certainly we must be proactive rather than reactive to the pandemic. These initiatives are mainly public health interventions, diagnostics, treatments, and the national vaccination program. Some of these include MySejahtera, for example, is an application developed by the government of Malaysia to assist in monitoring COVID-19 outbreak in the country, which is used for contact tracing, health self-assessment, check-ins, and built-in with AI capabilities for hotspot identification. It is also used for vaccination registration and vaccine administration. The use of geo-mapping to determine the distribution of sporadic and cluster cases. Geo-mapping, geo-fencing, these are important tools in public health. Dashboards for the use of hospitals, clinics, and health districts to monitor the situation real time. Virtual clinic services and telemedicine, digital innovation and R&D, AI, IoT, big data analytics, genomics, robotics, and blockchain technology in the digital response for the pandemic. Interoperable digital health records between patients and their multiple caregivers and wellness support system could help health system effectively identify the most at-risk population and facilitate the physicians to provide truly optimal care. The Ministry of Health Malaysia has announced plans for a nationwide scale-up of electronic medical records to all Ministry of Health hospitals and health clinics in phases for the next 5 years to achieve a lifetime health records. The first phase is to be implemented in Negeri Sembilan using an integrated health information system approach and is to be completed by 2023. If we can collectively continue to push for wider adoption and use of digital technologies, it could propel healthcare system to a new height, centered around real-world data, evidence-based medicine, and better patient outcomes. Ladies and gentlemen, this brings to my third point, building a multi-sector approach to encourage investment and resourcing behind innovation. Increased partnerships will be essential in making this much needed shift for prevention. This transformation can only happen if all parts of the system work together as one towards the same goal. We must build multi-sector collaboration if we seek to make the change sustainable. As a response to the pandemic, we have seen some exceptional partnerships and collaboration rising up and bringing together expertise and resources from all stakeholders in public health. For example, the collaboration between AstraZeneca and the University of Oxford for the global development and distribution of the university's potential recombinant adenovirus vaccine aimed at preventing COVID-19 infection. Another example is the COVAX facility co-led by Gavi, the Coalition of Epidemic Preparedness Innovation, CEPI, and the World Health Organization. In this facility, any country can join with others to pool resources and reserve COVID-19 vaccine doses for their population. Across these other examples, you can see the policymakers, academia, civil society, and industry are coming together, learning from the COVID-19 and ensuring we are not caught off guard by the next pandemic. Ladies and gentlemen, as we think and rethink our healthcare system for a post-pandemic world, we must create the right governance that will allow us to earn the public's trust and unlock rapid and concrete changes. Whether it is in prevention, digital health, or innovation, we need to create a better design and govern healthcare ecosystem. We must continue to explore and find more ways to facilitate coordination amongst all the players of the healthcare system, especially between the public and the private sector. We also need to forge greater alignment and coordination across the local, regional, and global dimension of public health. No one can do this alone, but if we undertake a concerted effort to work together, a new age of public health is achievable. We have already seen how this kind of coordination can work in the pandemic response when all stakeholders in the public health actively work together behind a single critical goal, and we can find solution to even the most difficult challenge. Together, we can make the impossible possible. Together, we can make the healthcare system a better ecosystem, integrating the public and the private. Together, we can make a big difference in the healthcare system in our country. With that, ladies and gentlemen, I thank you.
Thank you very much, Tan Sri, for the enlightening address where you have covered and touched on many points. You have highlighted the need for all stakeholders to work together and for many stakeholder engagement. You have also highlighted the importance of using data and digital technology, AI, geometric, health information systems. You have highlighted the importance of the need for better preventive management and for the sustainability of the healthcare system, as well as accessibility and quality are issues that we need to also take into account. And you have also highlighted the need for additional investment in the healthcare system, as well as for greater collaboration and better coordination to have the right governance in healthcare. So thank you so much, Tan Sri, for this very enlightening and informative special address. We will now open the floor for questions, and I would take some questions that will be posted on the chat room later on. But may I first, Tan Sri, start by asking you, I think this question that many of us living in the Klang Valley will be very interested to know. The MKN and MOH have now come up with very clear indicators and criteria to enable the move from one phase to another phase. And based on these indicators and criteria that have been announced, when do you, Tan Sri, think or predict that Klang Valley can move into phase 2?
Thank you very much. So I think we have been disrupted our planning earlier, because if you look into our planning in the 1st of June, we implemented the MCO and we wanted a very tight MCO. Likewise, we have done on the MCO 1.0. And within 10 days, we saw when we implemented the MCO on the 1st of June, within 10 days, we managed to flatten the curve, and then we can see a downward trend. That was very encouraging. And it continues to came down, the cases decreased until 24th of June. Then suddenly you can see there's an exponential rise of the cases. This is a real reason. I think we were still in the lockdown of MCO 3.0. But I think when we look into our studies, it shows that the virus have actually evolved. And we've been informed by IMR, the Delta variant is spreading. And today we know that the dominant virus now is the Delta variant. From 17th of July until August, there were 67 full genomic sequence being identified, the variant of concern, of which 66 were Delta variant and 1 Beta variant. So initially, this new variant comes in with a more infectivity and transmissible in our population. And we see that the cases went up exponentially at the point of, we were looking into R0 of 1.2. And we have been informed this new variant, the Delta variant, the infectivity is very high. And just to compare, the Wuhan virus, for example, last year, the R0 started from about 2.5, which means one person will infect 2.5 people. But now, this virus initially was reported as 5 to 8. That means if 100 people infected, they infect 500 to 800 people in one cycle. But CDC came up with a higher infectivity that is actually, they said, almost similar to the chickenpox of 11 to 12. And if it's similar to measles, it's about 18. That means one person infected will infect 18 people. So again, also we look into our measures, that is public health measures. We need to use both approach, public health as well as vaccination. So the public health approach that we used last year, without the vaccine, we managed to bring down the cases, flatten the curve right down to 1st of July. We have 0 cases being documented, single digit, well controlled after a short period of time. So our MCO 1.0 is short, sharp, and hard lockdown for only 4 weeks, and then we recover very fast. But the third wave came around after the PRN Sabah. At that point of time, we also in Ministry of Health suggested to MKN to implement hard, sharp, and lockdowns. But unfortunately, at that point of time, we also need to look into the balance, to strike the right balance between health and economy. So our suggestion then, if you read my article and published article, was on the 14th of October to go for a lockdown like what we did on MCO 1.0. But we decided to go for a CMCO, conditional MCO, to allow the economic sector to run. And obviously, we have no experience on the CMCO to be used, but certainly to balance the economy. And what it did was it brought down the R0 from 2.2 to right down to 1.2. But after 1.2, we are not able to bring it down below 1. So it hovers around 1.2 and 1.1. This is because the economic sector is still operating. And this is why we see there's a lot of infection at that point of time in factories and in the workplace and etc. So, and on 7th of December, we saw that we need to open up and the onus to the public to comply with the SOP. But the moment we allow interstate and inter-district travel, the compliance and the social discipline led to the increase of the cases in January. So we implemented the MCO 2.0 at that point of time, but again, allowing the economic sector to run. So these are the challenges that we have. And certainly on the end of January, we peaked at 5,725 cases. And then February cases coming down as expected. And we will probably anticipated that the cases will go down until a 2-digit by May. But somehow in March, we decided to open up many other sectors because of the economy, social, and etc. So thereon, we see the increase of the cases again. And when we did the lockdown, we were very optimistic that we can bring down the cases. It went down nicely until 24th of June. Then the cases spiked. And that was because of the new variants that we are anticipating. So with this new variant, it changed the dynamic and disrupted our planning. And now we have to depend not only on the public health measures, but we also need to depend on the vaccination. And for example, in Labuan on the 23rd of April, there were 7 seamen from the shipping industry flew from India to KLIA. They were supposed to be quarantined in KLIA, but somehow they took the domestic flight to Labuan on the 23rd of April. During the flight, I think they infected 6 passengers, and they were quarantined in Labuan, but the 6 passengers went back home and spread the infection. That was a Delta variant. And we were very concerned because there were 1,350 cases documented during a short period of time. Our hospital capacity in Labuan only limited to 120 beds and 4 ICUs. So we have to build a field hospital, 22 ICU beds, and converted the stadium to 650 additional beds. And although we still implement the public health measures, what we did was we flood Labuan with vaccines, vaccinate all the population in Labuan, 18 years and above. And between 3 weeks, we can see that we brought down the cases. And now you see Labuan have only single digit. Yesterday was 6 cases and 2 cases, etc. So which means the vaccine works with the Delta variant. And also similarly in Sarawak, we also step up the vaccination. And again, we have seen decreased admission to the hospital, decreased utilization of ICU beds, decreased patient being on ventilator, and last but not least, decreased fatalities. So with this in mind, so now we are looking into the Klang Valley. So we have stepped up our vaccination, and hopefully we will achieve about 50% of the public in the Klang Valley by 31st of August will be vaccinated. We are already seeing some positive results, whereby now in Klang Valley, we have seen when we started the peak 2 for the elderly, we have already seen in Sungai Buloh Hospital, the 60 and above admission is decreasing. Now we are seeing the 40 to 59, 20 to 39, the cases are decreasing for the last 1 week. So, I mean, in terms of hospital admission and also utilization of ICU beds. So that's where I think, even Negeri Sembilan, I was there last week, their admission also is decreasing. And even small hospital like Jempol, we have made it a full COVID hospital. The cases are less now. They're going to revert back to hybrid and probably to treat more non-COVID cases. So I think the impact already been seen in Klang Valley, but we need to see probably another week or 2 before we can see the significant decrease in the hospital admission. But the cases are increasing, not in Klang Valley. Klang Valley already stabilized the cases. We have already stabilized the daily cases. But in other states, for example, Kelantan, in Johor, Kedah, Penang, and then as well as Sabah, I think the cases are increasing. States that have shown a decrease is Labuan, Wilayah Persekutuan, Kuala Lumpur, Wilayah Persekutuan, Putrajaya, as well as in Negeri Sembilan, we are seeing the cases are coming down. So I think this, and Sarawak as well. So I think this is a good sign. So we hope that we can achieve, initially our herd immunity about 70 to 80%. If it's a Wuhan virus, is adequate, you can achieve 65 to 70%. But when the infectivity increases, then I think we need to, our target has to increase to more than 90%. So now we know that this Delta variant, they spread very fast. Transmission can occur within 5 to 15 seconds. And, and the R0 is very high, more than 10. So we need to take all the precautionary measures. The virus is already in the community. Make sure you double mask, put on the shield, and then social distancing if possible. Stay at home, or if you have urgent matters to deal with, perhaps you have to comply to SOP. Avoid crowded places, confined spaces, especially the ventilation, because this is the Delta variant is airborne. So if it's airborne, I think probably you wouldn't know where you get the infection. So that's the reason why I think we have to take precaution, and then to use the 2 approaches, public health as well as vaccination. And we see from Israel, for example, they succeeded in terms of vaccination to about 85% of the population, adult population. And then they relaxed their restriction, ease their restriction, no more masking, no social distancing, etc. And it said then, now because the new variant coming in, and certainly there's a rise of cases in Israel. So we expect more variants will come in because when you have infection, then you have replication of the virus in your lung. And the more replication occurs, the more chances the mutation will happen. And maybe another 3 or 4 more cycles, we can see spike protein mutation that is resistant to our vaccine, and also from our testing, we may not be able to detect them. So the fear is there, but we need to look into solutions, how best we can contain this infection in our country. Thank you.
Thank you, Tan Sri. There is a view that the COVID will become an endemic disease in society. The question is, do we need booster shots, and what other SOPs that you think we need to be adopting once COVID becomes an endemic in society?
For the COVID to become endemic, I think the first is that our concern is the fatality is quite high, and hospital admission. So if we can vaccinate our whole population, 90% or 95% of population, then we can live with COVID-19, which means you can get infected. Today, for example, during the peak one, program imunisasi COVID-19 kebangsaan, we vaccinate the frontliners. 425,000 frontliners has been vaccinated. Today, we see about 6,000 plus of the frontliners being infected because they deal with the COVID patients in the ward. But majority of them are stage 1 and 2. Stage 1, you don't even know that you have been infected. Stage 2, you have mild symptoms, cough, nausea, etc. But you can live with it. You don't need admission to the hospital. Only stage 3, we had about 10 patients. Because stage 3, you have lung pneumonia, but you do not need oxygen. Stage 4, you need oxygen, and stage 5, obviously, ventilation, etc. So we can reduce the hospital admission. So once we have vaccinated the population, and we can live with the virus, and those infected, you can stay at home. Just like what we did for H1N1, we do not do a mass screening, but only symptomatic cases will do the screening. Today, there's actually a heavy debate whether we should do mass screening or not. Now, if we move towards a mitigation and endemic situation, and lately, I think in Oxford, they discussed about this, there's no point doing a mass screening anymore, but you just screen in the mitigation, the symptomatic, and isolate them. So then we can actually live with the virus. So we live with the virus means we continue to put on a mask, face shield, social distancing, frequent hand washing, stay away from crowded places and even confined spaces and poor ventilation, especially the workplace. When you have an aircon room, that's where I think the infection can spread. But if we have been vaccinated, that means you still can get infection, but majority of them, I would say majority will be mild and asymptomatic. But you can be a carrier, and also some with comorbidities can deteriorate, but the numbers are less. So severity less, and fatality also less. So that is how then we can actually live with the virus.
Thank you, Tan Sri. There is also a question asked whether it was a mistake that we did not impose the same MCO1 lockdown when we had MCO 3.0, and whether this has caused the lockdown to be extended longer and causing more damage to the economy because of the lack of the hard lockdown that we had in MCO1.
Right. I think before I answer that question about the booster, normally the vaccines will provide coverage. I mean, our immune response for about 8 months to about 1 year. I think we are still waiting for more evidence to show that whether we need the booster. I think we do need the booster in time, but not yet. So that we hope that, and if we were to implement the booster dose, again, the rich country, the developed countries will buy all the vaccine. And again, no country is safe until every country is safe. So I think this is why we need to really vaccinate the global population. And this is where COVAX comes in to make sure the equity of the vaccine and etc. That's about the booster. So we wait for more data before we can actually implement the booster dose. with regards to the lockdown complements in terms of our public health measures. It is not, I mean, we learned it from China. They implemented the lockdown, strict lockdown. But lockdown should be short, sharp, and hard lockdown. And say, for example, 3 to 4 weeks. That's the maximum. When we implemented the first MCO lockdown, it works well. And to our surprise, within 4 weeks, we managed to contain the infection, whereby the tabligh group, they have gone back to their kampong and districts from Perlis until Tawau. So we know the infection will be, in within 2 or 3 weeks, there will be an exponential rise in the cases. So we did the lockdown and it works. But the cost of lockdown, one day, I think it will cost us about 2 billion, if I'm not mistaken. Then because of that, on the 14th of October, the decision is whether we could balance the health and economy, allow the economy sector, but other sectors, social, sports, and education sectors, we put on hold, restriction. So, and hopefully we can actually balance it out. So now it's actually how to strike the right balance between health and economy. Now, when there's a loss of balance, means loss of life and loss of economy. But when the CMCOs is being implemented, we learn from the experience. It takes longer period of time. So when it takes longer period of time, in terms of the mental health, the economy, and etc., the recovery is very slow. So as compared to our MCO 1.0, when it's short lockdown, fast recovery. Remember, after May, we allowed every sectors to open. And this is what you call RMCO, May, June, July, and August. We were doing very well. And this is, I think, now that we know that these are the two balance that we need to look into health and economy. So, but if our public, have high social discipline and social compliance, then we don't need a lockdown in the first place. For example, when you say there's no interstate travel, we still have 500,000 people going back to the kampong for Hari Raya, for example. And after Hari Raya, Aidilfitri, all states, documented increase of cases and became a red zone. And now even Hari Raya Haji, for example, again, you can see the increase of the cases following our lockdown. But I think there are more than 100,000 people went back home during the period of time. So I think, again, we need to strike a right balance between health and economy. Now, Ministry of Health, we advise the MKN, the do's and the don't. But we are looking into health perspective. But MKN have to look into, the National Security Council have to look into the economy, the social, and etc. So decision being made in the National Security Council. That's where we, Ministry of Health, we give our views in the health sector, but to consider the other sectors as well. So I think the question is how to strike the right balance. On the hindsight, everyone is right, everyone is an expert. But what is more important, the foresight to look into the country's progress and etc. Thank you.
Thank you, Tan Sri. There are 3 very short questions that were raised in the chat box. I will just quickly run through this with you. First, somebody has said that they had inconsistent results in testing. His daughter was tested positive in one center and then negative in another. A second comment was, can the MOH reach out to homeless people for vaccination? Because a lot of the homeless have not been addressed. The third question is, there is an improvement in cases, particularly in the stage 4 and 5, there's been a decrease, but we see more death in recent days. They're asking Tan Sri for an explanation. Why is this so? These very 3 short questions.
All right, thank you. When we look into the inconsistent results, we know that RTK antigen is not 100% accuracy. This is about 84.4 when we started in May 2020. Now the review shows about 90% accuracy. So every 10 cases, there will be 1 case that perhaps inaccurate in terms of report. So, for example, in Selangor, they did a testing for the communities testing, population testing, more than 100,000, reaching about 100,000. Positive cases about 3,300. When we repeat with RT-PCR, only 776 cases are positive. So which means only 0.7% of the population being tested positive. Likewise, in Wilayah Persekutuan, they did a population screening and less than 1% are positive. So RTK antigen have the shortcomings, it's not 100% accurate. No test is 100% accurate. So again, then what about RT-PCR? Now, RT-PCR depends on the swab. If you do an accurate swab, whether the sampling is adequate or not. So also it depends on the sampling. Most of the labs, public and private lab, have gone through stringent requirements in terms of quality control. So maybe the sampling will be the issue. And we do know that if you were to do a deep throat swab and the nasopharyngeal swab, nasopharyngeal is more accurate. So again, there are papers varies. Some shows a deep throat swab is more accurate, some show both, some shows, but in our series, I think the nasopharyngeal swab is more accurate. But that's regards to the swab. Then the homeless, we are doing the vaccination for everyone. The concept is whether you're documented, undocumented, homeless or not, we will vaccinate. That is our principle. We started vaccination in phase 1 for healthcare workers, phase 2 for elderly, comorbid. Now we are moving on phase 3. Phase 4 for the industries, for example, target group, and we also have various processes of vaccination. I've been to a few, home visit, for example, giving the vaccination to the vulnerable population, bedridden patients, and etc. So the homeless, I think we are also looking into it, and then we can gather them. And the vaccination, for example, in Wilayah Persekutuan Kuala Lumpur, the vaksinasi COVID-19 gelandangan Wilayah Persekutuan Kuala Lumpur, Fasa 1 and Fasa 2. Fasa 1, 119 and they have been given second dose. Fasa 2, 133 people have been given. So this is under the Federal Territory Administration. These are a very good initiative being given to them. What about, I forgot your last question. Can you repeat?
It is relating to the death rate, that death has been increasing, whereas there's been an improvement overall.
Yeah, okay. With regards to the BID and death rate, so many of them that been infected, they have comorbidities in that sense. That was initially when we see cases coming in. Then when we look into the new variant of virus, they're affecting younger population resistant to treatment like steroids and etc. So this group of patients, for example, 20 to 39 or 40 to 59, if they are resistant to treatment that we are giving, we will do the swab and send it to the lab. And majority of the cases are the variant, which is why affecting the younger age group. And some of them comes to the hospital at the later stage rather than early stage. So at the later stage, whereby there is already pneumonia and massive lung inflammation and disruption, and then probably then I think the outcome is not that good. So now what we tell them is that to monitor themselves and come to the hospital early. And when we look into the BID, brought in death, some of them not registered with us, some of them no test has been taken, some have been taken but not did not follow the advice from the doctors and etc. So there are issues. So what we are doing now is that we are increasing the beds for oxygen and etc. Now, like renal failure, you need hemodialysis machine. Now, COVID-19, majority of them need oxygen. This is why we try our best to provide the oxygen. 94% of the patient in Hospital Tengku Ampuan Rahimah needs oxygen in category 4. That means if you can give them oxygen in a very early stage, you can perhaps reverse them, and rather than they progress to category 5 that need ventilation. So if you can catch them early, this is important for us to manage them early and before lung destruction or inflammation occurs widely. So that's where I think now we need to look into the category 1 to 5. Category 1 and 2 can be managed at home. But if you deteriorate, then you have to come to the hospital as soon as possible. So we have actually stepped up the ambulances services and make sure that those patients, for example, deteriorate, comes to the hospital early. BID, we see BID, there is actually 58% of them, more than 60% of them have comorbidities. That means they have other diseases and etc. And only 39% or 40% have no comorbidities. So we try to catch them early, the high risk group. So if the high risk group assessment shows that they are high risk, even in category 2, we admit them in our PKRC to monitor them, which means this is a 60% that they will deteriorate. But the younger age group, sometimes they think that, they have difficulty in breathing, for example, but they say tomorrow only they go to the hospital. But they couldn't even make, the next day, I think they pass on. So these are some of the challenges, awareness that we need to give them the information to seek treatment early. But not all patients need to be admitted to the hospital. As I said, category 1 and 2, 98% of them can be monitored at home. But only 2% that we must identify, risk assessment be made and then identify them early to prevent death. So we are trying to our best to address the BID as well as death. So we are also using a lot of new drugs now. For example, baricitinib that we start very early, stage 4, stage 3, 4, so that they, to prevent them to progress to stage 5. And we also have gone through a lot of trials. Now we are doing the WHO clinical trials. 3 new drugs being identified, and hopefully there will be impact. But whatever drugs that we used in the past, the solidarity trials have shown that it's not effective. For example, lopinavir, ketonavir, favipiravir, remdesivir, and all these are not working. And hydrochloroquine, once upon a time, everybody talked about this anti-malaria wonder drug, but again, it's been proven not effective. So now we're talking about ivermectin. Again, it's very inconclusive. In vivo study, the external study, there's some results, but in vitro study, there's some results, but in vivo in our body, then the method is inconclusive. Then you need a very high dose of ivermectin to achieve an antiviral effect, and that high dose has some complication that has not been mentioned. Anyway, we are doing the clinical trials. The trials should be available. The results should be available by next month, and we'll see. We take on from there.
Thank you very much, Tan Sri. There are a few other questions that are not COVID related, and I hope, Tan Sri, you may be able to also comment on this. One is a question raised on nutrition and physical activity that has caused obesity in a lot of Malaysians. I think that's a challenge that we face. We all love eating anyway. So the question is, what plans does the MOH have to overcome the obesity challenge?
Right, I think it's an ongoing plan that we have even before COVID-19, looking to address obesity and also undernutrition. These are the two. We have extreme now, undernutrition and over nutrition, for example, obesities, etc. So we have put on we are under the NCDs and address the issues of nutrition, the quality of food, and etc. And also the physical activities, engaging from younger age group to embrace sports, physical activities, exercise, and then to live a healthier life. I think the programs have been discussed with the Ministry of Education and to roll out the implementation on both sides. So the details of this has been drafted, and hopefully will be shared. So, for example, in adults in Malaysia, overweight or obesity is about 50%. And adult in Malaysia has abdominal obesity is 1 in 2, also about 50%. So I think this is the approach. We need to look into a more holistic approach in terms of NCD. That's what we mentioned about prevention, awareness, and how can we balance this life, our activities, and etc. I think we need to emphasize on the prevention. For example, diabetes, high blood pressure, heart diseases, regular checkups, and embrace digital technology in terms of to make sure that they embrace in terms of the calories, for example, daily calories, and exercise, how many steps per day that they are taking, and make sure that they step up their activities, daily activities. All this can be done if you embrace the digital transformation in prevention, and in terms of, and also quantify the intake, daily intake, for example. So I think this is a huge topic that we can discuss, but now the focus is on both, and mental health also must also take into consideration. But in a nutshell, we are looking into the whole healthcare transformation, and trying our best to integrate the public and private and ride on the digital technology for us to improve the quality of health in this country.
Thank you, Tan Sri. There's another question that has been put up, and that is, does the Ministry of Health encourage the setting up of more private hospitals and specialist centers, and whether there would be incentives given to private hospitals to bring in more foreign specialists?
Thank you very much for that. I think we have been talking about healthcare transformation for the last 35 years. The healthcare transformation and health financing, I mean, trying to integrate the public and the private sector. Meaning, if we have, financial support for every individual in this country, they can go to the private sector or the public sector, depending on the quality of care and the services. Now, if they have the insurance, for example, health financing, if the hospital and services is good in the public sector, they'll go to the public sector. So, and then the public sector will try mainly on the financing. Today is everything is free and token payment. But I mean, so the strategic purchase of the services in the public and the private. So we have started in terms of looking into our Protect Health PK B40. So we started this group of B40, doing the screening for them, and I think the clinics are doing it, and then doing a basic tests and in the clinic, and then if they are diagnosed with diabetes, hypertension, they will be referred to the public sector. So today we think that we can actually extend to treatment, but this is B40 because B40, whatever system that you have, the government is funding them. So hopefully by doing so, we can allow treatment in the GP clinics for NCDs, for example. And today GP clinics are coming in to help us in the vaccination and etc. So I think that is one model that we can actually expand the public and the private sector resources together to address the issue of healthcare in the country. And to balance in terms of health expenditure, it's almost the same, 50% and 49% in the private, 51% in the public. But if you look into doctors, we have 71% of doctors in housemen, including in the public, and then 29% in the private. But the health clinics, we only have 10% in the public sector, 90% in the private sector. So now, if we can integrate the services, public and private, to have one care system, not two dichotomous healthcare system, one care system, and there's funding to come to public and private. So we certainly encourage more private hospital, but mainly now the funding, we need to address the issue of funding. Majority of private hospital is in the urban area because those who can afford to pay. Now, if we have a financial system, then rest assured the private hospital will be set up in the rural area because the government is paying in terms of all the financial system is paying for the individual. So whether they are poor or rich, they have a healthcare system, healthcare financing and insurance. So that is something that we are looking into it. Now, next issue is with regards to the foreign specialists. Now, unless there is actually a shortage of the specialists in that specialty, then we can consider case-to-case basis. And then this is why they have to register with the NSR, National Specialist Registry, and for them to practice in this country. So at the moment, priority obviously given to our local, but if there's shortage, we can actually allow them to come in to register with NSR and practice in this country.
Thank you, Tan Sri. There's a question raised now about the Lambda variant, that it contains more mutations and could be a lot more infectious. Question is the public health sector already under tremendous strain able to sustain if and when the Lambda variant become more prevalent here in the country?
Yeah, now when we look into whatever variant, the public health measures still the same. Let me highlight the 6 principal areas of the public health measures being taken. Number 1, border control. So we have implemented this early. For example, during the first wave, Wuhan virus. So we need to strengthen and tighten the border control. Now we are not only looking at international border, we also look into regional, interstate, and even inter-district. So border control is very important. So for us to, now that we know that there are many variants out there, Lambda is only one of them. And we have Epsilon, we have Eta, and etc. Now, Lambda variant comes from, been documented in Peru. Now it has spread into many South American countries. And what I have been informed that to date, there are 34 countries already have local transmission of the Lambda variant. The fear of Lambda variant is that, probably is evasive to our testing. That's number 1, meaning that the virus is in you, but for you to detect the virus, it takes time until the volume is very high, then only you can detect the virus. We are seeing this also in the Delta variant. The Delta variant, the Mercy flight that we took Malaysian returnees, although they have been tested negative in India, when they arrived, we tested them, 4 of them positive. Then on day 18, then we realized 20 of them positive. So they are harboring the virus, but during the incubation period, you cannot detect them. So that's one. Second is that we are worried the vaccine that we use today is going to be resistant to this Lambda variant. At the moment, that's our biggest concern. If that is so, then we'll start all over again in terms of the vaccination and etc. So our public health measures, number 1 is border control. Number 2 is looking into the health system response. That means our hospital services and etc. So today you can see, for example, the cases goes up, our hospitals already fully congested, ICUs beds not available, and etc. So that is the second, to get our preparation to increase the beds, and how do we respond to increased demand of cases coming to hospital. Third is the public health measures. These public health measures looking into basically contact tracing. Find, track, trace, actually isolate, and support. FTTIS, that's basic what we have done since early. And this is where I think we can harness on the digital technology. MySejahtera, we started very early, and now MySejahtera in last 18 months has evolved tremendously from a simple software application, and now I think in use widely in the hotspot identification, for example, and then using AI technology, contact tracing, health self-assessment, and then vaccination and so forth. So we hope that we can enhance the technology in the public health. Then fourth is the vulnerable population. So earlier, we already have implemented this vulnerable population like orang asli, longhouses, and certain state, the green zone state, in terms of to make sure that those coming in the states are not bringing the infection. And then fifth is the engagement in the public, the do's and the don't. So our tagline then was stay at home, because if you stay at home, if you are positive, then you are not infecting the communities. If you are negative, you stay at home, you're not getting infected. But nobody can stay at home forever. So, but you need to go out. If you go out of your home, make sure that you comply to the SOP. So I think that message has been, drummed into our public. But the most important is to embrace that message, not only to practice it, and hopefully that can give us the external protection. And the vaccination will certainly give us the internal protection. And last but not least, it is the public empowerment. So we need to empower the public to take care of themselves. We cannot win this war without the public coming together and practicing, because everyone actually is exposed to the virus. And although Ministry of Health can give you the guidelines, but the onus is on you in terms of self-quarantine, take all the precaution measures, wash your hand. We can't wash your hand for you, but you have to wash your hand frequently and avoid crowded and confined spaces if possible. Make the right choice for you. Protect yourself, your family, and your community. So that is the message that we can guide, but it has to be practiced by the public. So these are the 6 public health measures. Whether it's actually a new variant or not, we will need to tighten all these public health measures so that we can contain the spread of the new variant in our country.
Thank you. That's very good advice from you. And we hope everyone will comply with those procedures and the advice that you have given. We have probably one last question that I would like to pose, and that came from the discussion yesterday from many of the speakers and the doctors have spoken. And that is to ask you, sir, for your thoughts on what you think are the key priorities for healthcare reforms in the country, and also your thoughts on the proposal to set up a National Health Commission.
I think, yeah, these are very two important questions. I think we have discussed this many years. Our key priorities, looking back now, we must invest more in public health. I'm a surgeon. Many of us in the medical fraternity, we go for, discipline, like cardiothoracic surgery, cardiology, and all that. But we need the best brain in public health. Today, you can see we are underinvested in public health. And very important, the public health, I think, is a wide spectrum. And we need to really recognize the subspecialty in public health so that we can develop the forte of public health in IT, for example, in all the areas. And we need to really focus and give attention to public health. In those days, I think, the best brain goes to the medical or even, other discipline rather than public health. But now, I think it's very important for us to look public health seriously and develop, for example, the CDC, and develop, the greater the planning for public health in this country, because this is beginning of a pandemic. There will be more pandemic to come, and we need the experts. And you can see that, public health is looking into our lives and livelihood. For example, you talk about just now obesity, you talk about in terms of exercise and etc., physical activities. These also need public health experts. So I think in all areas, in all ministries, they should have public health experts. And we are short of public health experts as compared to 5 years ago. So training on the public health experts and trying to get more people to take up public health as their specialty. I think this is the first thing that I will look into it and give priority to the healthcare transformation. Second is that looking to the how can we integrate the public and the private sector. Today, you can see during this pandemic, we need to work together, public and private, coming together as one. The dichotomous healthcare system is already obsolete. We need to bring the experts on, looking into country's perspective, not the sector, whether it's a public sector or private sector, but how do we integrate the two systems? Now, the integration, we have to address the financing of our healthcare system. We have been talking about financing for 35 years. To have a single financing, which means everyone have the option to go to the private or the public sector based on their financing. So B40, perhaps it will be subsidized by the government, but M40 or the T40, it must come with perhaps our occupation. So when you apply for a job, the healthcare services or the healthcare will be taken into consideration and covered by the companies and etc. I think that is important. And then we have to invest in prevention and healthcare and awareness. I think that is the most important, rather than we are poor in maintenance, and then, when we do have a poor maintenance culture. So when we come in a very irreversible stage and a complex and complicated complications, for example, it costs more to the healthcare system. So I think we need to really invest in the prevention care. This is lacking in our country. So we can improve, and this can be enhanced by technology. So in the healthcare, probably healthcare transformation, we look in digital transformation, we look into precision medicine, and how can we embrace digital transformation and precision medicine in public health, in our services, health services, in our training, and as well in our research. So you can see, for example, the research in solidarity trial by WHO involving 53 countries, and more than 220 hospitals around the world. This is one of the largest, in terms of country and hospital involvement to try out, to look into 4 drugs, remdesivir, interferon, looking into lopinavir, as well as hydrochloroquine, and then we got the results, and the result is transparent and accurate in terms of what to do, what not to do. So, and training using the digital transformation. I think that is the more important. And Health Commission, we have discussed whether Ministry of Health can be like other sectors, like the judiciary sectors, to have a health commission running the country, the health services. But I mean, that has been explored, but again, whether we can be independent in that sense, autonomous. Now, when we talk about one care transformation at one point in time, the Ministry of Health is looking only on policies, but not running the services. That means we are looking into policies, but the hospital will be all autonomous, and they'll be given the certain funding or the financing, just like a private hospital, purchasing from the public hospital as well as the private hospital. That was the model that we discussed. But we need to have all the experts to come together to agree that the healthcare transformation can move on. There's a lot of objection. When we propose the private sector, sometimes they do not agree because they are still comfortable with what they have today. But how can we bring both parties together and discuss to come up with one path, one goal in terms of transform our healthcare to maximize and optimize our resources in the country, be it in the public sector or private sector, so that we can provide a good quality, equity, and access of healthcare to our public.
Thank you, Tan Sri. With your kind indulgence, there's one last question that has been put up, and probably that comes from a young doctor serving in one of your hospitals. He or she was saying that there has been a recent circular that has halted specialist training for 3 months and wondering whether there's any way out of this. But the person also thanked the Ministry of Health for all the efforts that you have made. So Tan Sri, can you kindly comment on this?
We are looking at the resources. At the moment, we are in a war. We are in a war with the virus, against the virus. Now we are short of our resources in terms of human resource. We are opening up a lot of beds now. Hospital, Pakar, Kanak-Kanak, UKM is empty. It's a brand new hospital, but without human resource. So we need to mobilize our human resource from Ministry of Health. We need to mobilize our housemen now. Houseman training, they will be considered 3 months, for example, will be taken into account if they have been based in the ICU or even the wards of the COVID patients or in the COVID centers and etc. So we have mobilized the housemen. We have mobilized our post-basic nurses. We need to mobilize our specialists as well. So what the circular is to put in 3 months, put on hold 3 months for them to assist us. We are in a war. We are not in the normal times that you can continue your education. So if that's the case, if they are already been in campus, then they will have to serve the in campus in treating COVID patients. Some are out campus, like in Ministry of Health, postmasters, master student. So they will be, placed in the COVID ward and etc. Even our operating, OT operating rooms and our specialties, surgical specialties already put on hold. We already postponed all elective surgery. Only emergency surgery we are doing it. And also we are referring some of the semi-emergency cases to the private hospital. These are non-COVID cases. So what about our surgeons now? I mean, if you close the theaters, what do they do? Some of them are assisting us, but we also allowed them to go to the private hospital as to do some of the cases, so that we maximize our beds in the public hospital. Again, this is difficult times, extraordinary times, whereby we need to increase the resources. And those working at the ground frontliners, they've been working 18 months non-stop. It's only right that we sacrifice the 3 months to help them at the ground level, so that to rotate and also to, and the cases are now increasing. So we expect the cases to maximize, to peak probably next 1 or 2 weeks before we see a downward trend. And depending on our vaccination. So we are seeing it now, but we hope that after 3 weeks, then the cases will be less, then probably they can return to their respective position and also training. So I think this is only a time that we also allow the private doctors to come to the public hospital and vice versa. I think this is where we have to work together as a team. So we are in the extraordinary times. We need extraordinary measures, and this is one of them.
Thank you so much, Tan Sri, for your very open and candid response and answers to the many questions that have been put forward during the last 1 hour. This has been a fantastic and fascinating dialogue with you. Many of us have learned a lot. We are so grateful for your open sharing with us. We wish to thank you once again for being present with us today and continue to wish you and all of you in the Ministry of Health continued success in the war against COVID. You are an inspiration to many people in Malaysia. So, sekian terima kasih, Tan Sri.
My last word is let us all come together to fight against the virus, not against each other. With that, I thank you.